Preeclampsia is a pregnancy complication characterized by high blood pressure and signs of damage to another organ system, most often the liver and kidneys. And preeclampsia usually begins after some 20 weeks of pregnancy in women whose blood pressure had been normal. As the world marks the day today, we'll also look at how to tackle this. And we have joining us on the show. Good morning to you.
Good morning, sir.
Good morning.
So, Dr. Pong.
Yes, Dr. Pong is my name.
All right, so thank you so much for joining us on the show.
Pleasure.
So, let's get to the ball rolling. What is preeclampsia?
So, like Roland alluded to in part, it is a new onset hypertension in a pregnant woman whose pregnancy has gone past 20 weeks. That summarizes it. Now, in broader terms, we refer to something called pregnancy-induced hypertension. And pregnancy-induced hypertension has other forms, which is a mark of severity of this new onset hypertension. In its mildest form, there is only an elevation in the blood pressure, which we also call gestational hypertension, meaning that the hypertension came about purely as a result of the pregnancy or the gestation. Now, the next level of severity is what he described as preeclampsia. And in preeclampsia, we have a new onset hypertension or gestational hypertension plus presence of protein in the urine. Then the next level of severity, or probably the most severe form, is when a woman who has this preeclampsia has also developed a fit. We call that one eclampsia. So if you like, preeclampsia is like a prelude to eclampsia, which is the most severe form of the disease entity that we call hypertension, pregnancy-induced hypertension. So if you like, it's like a progressive disease which spans from a mild end of the spectrum to the most severe form, which is the eclampsia.
But at the end of the day, there will be some pre-existing conditions. What may be precipitating, or what are some of the risk factors, so to speak?
Right. So the risk factors are predominantly patient factors. For instance, the age of a woman can predispose her to developing preeclampsia. And we know that for age, women who are the extreme ends of the reproductive age, i.e., either too young or too old. By too young, we are saying predominantly those who are less than 20 years. And by too old, well, it's semantics, those who are primarily above 35 years. So women at the two extreme ends of reproductive age are at risk of developing preeclampsia. Then also, women who are embarking on their first pregnancy are at a higher risk of developing preeclampsia than those who have been pregnant previously. That doesn't mean that if a woman has been pregnant previously, she cannot develop preeclampsia at all. But all we are saying is that first-time pregnancy is a higher risk. Then those who are obese, those who have other medical conditions like renal disease or kidney disease, those who have diabetes, those who have something we call connective tissue disorders in general. Women who have had preeclampsia in their past pregnancies are also at about 10% increased chance of developing preeclampsia in subsequent pregnancies.
Now, how can you prevent it?
Well, preeclampsia in itself, we say, is not preventable. But its severe forms or the complications are preventable. We are saying it's not preventable because up till to date, science hasn't been able to come out with the exact cause. Remember, we've talked about risk factors. Those risk factors may not necessarily be causal. And because we don't know the exact risk factors, the exact cause, it is difficult to talk about preventive measures. However, there have been some attempts at trying to reduce the risk. For instance, if a woman is obese before pregnancy, can we encourage her to lose weight? If she has diabetes, can we control the diabetes? Or if she has renal disease, can we deal with those before she gets pregnant? Then more recently, there have been some studies that suggest that, for instance, using aspirin, low-dose aspirin, in women who are known to be at high risk of preeclampsia can reduce their risk of developing preeclampsia. Again, it is believed that in population who live in areas where there is low level of calcium in their diets, if you give them calcium supplementation during the pregnancy, probably we can reduce their risk of developing preeclampsia. But like I said, generally we'll say it is not preventable because these evidence that we've gathered are not that strong. It may work for some portions of the population, it may not work for everybody. But by and large, that is what we know so far as prevention of preeclampsia is concerned.
Okay, but what's the picture then around Ghana? Because now we're mentioning areas that usually would have women with some nutritional levels at a certain point or not having access at all. So what really is the infographics for it across Ghana?
Well, preeclampsia, like other hypertensive diseases, is on the increase. Remember, I've alluded to age and obesity as being some of the risk factors. Increasingly, women, particularly those in urban areas who are engaged in formal education or formal work, are delaying pregnancy and therefore are getting into the higher ranks of the age, so probably increasing their risk of developing preeclampsia.
I don't get you by that.
Okay, so what I mean is that in the olden days when you could find somebody in Accra, big towns, by 2024 probably started family, because of work that women are now developing their career. Okay. A lot of them are delaying the onset of pregnancy and therefore are gradually getting into the age bracket where their risk of preeclampsia is increasing. So if a woman gets pregnant and gives birth the first time at an older age, that woman is at risk. So because of that, we are beginning to see the increasing picture of preeclampsia. Again, obesity is increasing, particularly in the urban areas. So again, that's also increasing the risk of preeclampsia. I always say that about 10 years ago, I did about 8 months rotation at a district hospital in Ghana. There, the preeclampsia rate was so low, in fact, around 2%. Then I finished my rotation, and then the women were all smallish, short. Then I finished my rotation, come back to Kolebu, where I work, and suddenly everybody, I see that the labor ward looks fair and big and tall. So it is not surprising that in Accra, we tend to have a lot of preeclampsias. And indeed, the rate of preeclampsia in our teaching hospitals where some studies have been done suggests that we are talking about 5 to 7 to 8%.
But is it not because perhaps maybe the teaching hospitals and the main hospitals are more of referral centers? So
that is part of the story. But I'm not talking about only the teaching hospitals, but the whole of Accra.
It's the demographics.
It is the demographics. The demographics certainly have a role to play.
Well, you wanted to ask a question?
Now, let's talk about the complications surrounding it.
Okay.
Yeah.
So preeclampsia, like hypertension, is a systemic disease. By systemic disease, it affects nearly every known organ in the human body. You can talk about it right from the brain down to the foot. Now, the severity of the complication depends on how long this has been going on for. So, for instance, we know that preeclampsia can affect the brain. That is when it causes the seizure. The seizure is a disorder of the brain, and that's when they have eclampsia. It can actually cause stroke in a young woman who's pregnant. It can cause blindness. Most of the time, that kind of blindness is temporary because a lot of them are reversible. Can affect the lungs, cause pulmonary edema, where the woman suddenly cannot breathe because her lungs is all filled with, if you like, water. Can affect the heart. Can cause heart failure. Can affect the liver. You alluded to the liver in your introduction. Can cause the liver to rupture for the woman to bleed. Can cause a lot of derangement in the metabolic profile of the liver. Can affect the kidney, can cause acute kidney injury, or if you like, acute renal failure. A good number of our patients in Kolebu have required dialysis because of kidney failure from preeclampsia.
Does it mean chronic?
Most of the time they are acute. If you're able to dialyze them early enough, you're able to reverse the injury, and therefore they can regain their kidney function. But if you don't manage the acute phase early, it has a possibility or potential to proceed to a chronic kidney disease. Can affect the womb in which the baby lies. Can cause the woman to bleed heavily. in the course of the pregnancy. We call that abruptio placenta, or premature separation of the placenta. And once the placenta separates, there is no communication between the mother and the baby, and the baby can die instantly.
Wow.
So if you look at it, it affects so many organs in the body.
Sometimes women in gestation, or perhaps within that period of pregnancy, tend to have their tooth removing, etc. Is it part of it?
No. Okay. In places where you found pregnant women losing their teeth, it's as a result of deficiency of calcium. You know, and sometimes it may come about because during pregnancy they vomit, so become their calcium in regions where calcium intake is not good enough, they become low on calcium, and that can cause them to actually lose their teeth. It has nothing to do with preeclampsia per se.
Okay. Now, as a first-time expectant mom, what are the signs I should look out for?
Okay. So, and for an expectant mom, when it comes to pregnancy-induced hypertension or preeclampsia, the key factor for diagnosis is elevated blood pressure. However, before that happens, you notice that some women will begin to gain weight rapidly in the course of the pregnancy. Part of them may notice swelling of their feet, and sometimes swelling of their faces as well. Sometimes even their fingers may become a bit swollen. So you notice that for a young woman, suddenly her ring doesn't fit anymore. Those are signs of fluid accumulation in the body, which tend to be associated with an elevation in the blood pressure. But the key factor for diagnosis is an elevated blood pressure and when there is spillage of protein in the urine. Let me emphasize that just swelling of the feet, what we call edema, does not mean a woman has developed preeclampsia.
Okay.
But most of the time when they have preeclampsia, they tend to have swelling of the feet as well.
So you're saying
if a woman notices,
that's a precondition?
It is not a precondition. Just to say that if a woman notices swelling of the feet, of the face, and the hands, go have your blood pressure checked and be sure that the blood pressure is normal. Once the blood pressure is normal, you don't have preeclampsia.
Okay, so now let's come to what we tend to do to manage the cases. We just had a colleague who did a great investigation about how, and we did a premiere, how religion and sociocultural perceptions and issues tend to affect the way we handle pregnancy and where they even give birth. How is that a main concern for you as a health practitioner in the way we manage preeclampsia or eclampsia?
Okay, right. So we can look at it in maybe 2 or 3 forms.
Okay.
The diagnosis of preeclampsia relies on measurement of the blood pressure and presence of urine in the protein in the urine. Now, these 2 measurements mostly is done in hospital. So for this diagnosis to be made, it means the woman must come to hospital or to a place where these parameters can be checked. So if whether the cultural or religious practice discourages a pregnant woman from coming to hospital, then it becomes problematic. There are situations in some homes where pregnant women cannot on their own get up and say, today is my hospital day, antenatal day, I need to go. There are so many levels that the woman will have to overcome. Getting permission from husband, from in-laws, if they're living in a family house. And therefore, these kind of places delays in the pathway of the woman for access to the hospital. So these are issues that can be problematic. There are some churches who don't even encourage their members to seek orthodox medical care. And if a woman is pregnant, either she has to go to a prayer camp or go somewhere, even labor and delivery, they discourage them from coming to hospital. So that can be problematic. Again, there are instances, quite funny these days. A woman comes to hospital, you make a diagnosis of preeclampsia, and very often, when you make that diagnosis, the only cure for the condition is delivery of the baby. Or if you like, termination of the pregnancy, whatever point you have reached. That decision is often difficult for a lot of people to make, especially when the baby is not matured enough to survive. Then you have a very long process of consultations and back consultations that the woman and her family sometimes have to make. because a pastor or a faith leader somewhere has told her somewhere that, hey, no intervention, just allow everything to go on well, and that can cause a lot of problems.
Well, so we're willing to open the phone lines for just 5 minutes, just receive 2 or 3 calls. So wherever you're watching us, we're discussing preeclampsia. Today is a day that has been set aside the world over to take a look at it, do some sensitizing education on it. We have the numbers on your screen right now, 03022116991 or 2. We have Dr. Samuel Intriopong, who is with the University of Ghana School of Medicine and Dentistry, helping us do great education, also a specialist in gynecology and obstetrics. That's it. Right. Big man, big pose. But but as we go further away from the urban areas, do we have more of such cases that are not well managed? Let's say in the northern half or in more rural communities.
I must say that the management usually shouldn't be much of a problem, particularly at the health facilities, because if the woman comes to an established health facility with the right personnel over there, the basic management most of the time is available. The challenge often is when the woman doesn't get to the health facility early, or maybe they are told of the need for intervention and they do not agree with the way to go.
All right, let's take our first caller now. Let's go to Yao Betaton in Cape Coast. Good morning, Yao.
Good morning.
Good morning. So you can go ahead with your question.
Yeah. Okay, I want to ask a question about the diagnosis that the doctor talked about. You mentioned that for the diagnosis of preeclampsia, there are 3 key factors you have to consider: protein in the urine, and then elevated blood pressure and edema as well. And you mentioned that if there's protein, and then I want to know if there's protein in the urine, that the blood pressure is somehow normal, and there's edema, so can it be same as preeclampsia? That's my question.
Okay, can we take the second caller too? Take the second.
All right, so let's go to Takoradi.
And we have Hawa Nesima. Good morning to you, Hawa.
Good morning, sir.
You want to make a contribution or ask a question? Please go ahead.
Yeah, I want to ask a question.
Please go ahead.
I'm pregnant, and I went to the hospital after the unit test. I realized that they wrote straight /negative. When they should have told me that maybe they have found something like this. But my book was given to me after the consultation. I came home, went through, and I saw something like that. So I think that when we go there, they are supposed to let us know our conditions there. Maybe this is what you are going through. This is what can be done. But when maybe you do your regular test and you come, you don't have knowledge about that. They are the experts. So they have to let you know your condition and how best you can manage it. And sometimes when you go, I really want this clarification. That doesn't necessarily mean that when you are pregnant and you put on weight, that is when the baby also gain weight, or it does not necessarily mean that. Because sometimes when you go and they check, they say, oh, your weight is this or that. You get a little bit confused. But if you happen to read, I have a history of diabetes and other things. So I'm more cautious of what I eat and how to prevent those things. So I don't know.
Howard's point has been made. Howard's point has been made. Now, please tackle the two.
Okay, so let me start with Howard's point. During pregnancy, every woman is expected to gain weight. And there's a certain amount of weight gain during pregnancy that is expected during...
The BMI is still important?
BMI is not very important during pregnancy.
Okay.
However, there's a certain amount of weight. And we expect that for women who before pregnancy had normal BMI should gain up to about 12 kilos during the pregnancy for the pregnancy outcome to be good. Some can gain more than that, and those are the ones that may be at risk of pregnancy. If you don't get up to between 9 to 12, it means that the baby may not do well. So there's a certain ideal weight that every pregnant woman must gain for the pregnancy outcome to be good or to be optimal. Let me attempt a question about education.
From you.
That is always challenging. But I will expect that every health worker should communicate the results of the test with the client as she presents herself with a test report. But I will also encourage clients to talk to their health workers, midwives, nurses, doctors, this is my report. I've seen they've written something trace. What does that mean? And I believe most of the time they'll be willing to explain. Then the first caller asked about diagnosis of preeclampsia based on 3 prongs: hypertension, presence of protein in the urine, and edema. Let me say that edema is not a requirement for the diagnosis, but the key factors for the diagnosis is hypertension and presence of protein in the urine.
Okay.
So now, today being World Preeclampsia Day, what are you doing?
I guess our work still continues to create more public awareness, to educate the clients who come to us, and through whatever means that we have access to them. And I believe it's in line with this program. I think it's a very commendable one, so that those of our viewers at home and those who maybe encounter us either online or anywhere will get to hear that indeed preeclampsia is an issue. Probably an aspect that we didn't talk about is the figures and its impact on even death. Over the years, we believe that bleeding or hemorrhage is a leading cause of death during pregnancy and delivery. But increasingly, impact of hypertensive disease during pregnancy, and for that matter, preeclampsia, is also very high. Indeed, we know that in about 3 or 4 of the major hospitals in Ghana, preeclampsia is now or hypertension during pregnancy is the leading cause of maternal death, contributing in some cases up to about 20–25%
of cases
of maternal death.
Wow.
And therefore, it's something that I believe we all need to talk about and do all that we can within our limited resource to either reduce the impact on pregnancy and, most importantly, prevent the unnecessary deaths.
Okay, let's go to the phone lines. Divine Adevu on the phone. Good morning.
Good morning.
Yes, your question, please.
Yeah, please, my wife. Yeah.
You can go
My
ahead,
wife-
Divine.
Yeah, my wife had the same problem just some few weeks ago, and the baby was taken from her. Hello?
Yes, we're here, Divine. We can hear you loud and clear.
Yeah, so I wanted to know if subsequent pregnancy, what are some of the steps we can take so that such incidents cannot happen?
All right, thank you so much for your question.
And he will be our last caller.
Is it the baby was taken from the wife?
Yeah, I think that's removed.
Oh, okay, before, because of preeclampsia.
Yeah.
Like I said, there are some few interventions that have been tried to reduce the risk of preeclampsia. And in this case, I will advise that first and foremost, she books early when she gets pregnant. In fact, it will probably be better for her to see a gynecologist up to about 3 to 4 months before she gets pregnant. And when she gets pregnant, she should start antenatal care early. So some of those interventions that I've talked about can be put in place and see whether it will help her as an individual. Remember, it may not work for everybody, but it may work for some individuals, which maybe they can explore. And most importantly, you should try and go to a hospital that has specialists over there. Because sometimes delivering the baby early can also be problematic. But if you have the specialists over there, then every effort will be made to ensure the survival of that baby that may have been born premature.
All right.
Okay. Well, thanks for joining us. We've had in the studio Dr. Samuel Entry Opong. Is it Opong Entry or Entry Opong?
It's Entry Opong.
Entry Opong.
Yeah.
Okay. Looks a bit unusual than the usual Opong Entry that we have. Right. He's with the University of Ghana School of Medicine and Dentistry, but also a gynecologist and an obstetrician. I hope I pronounce it right. But we'll bring you into the studio for more education on all things sexual reproductive health and all the things that we need to know about women as well.
That'll be my pleasure.
Well, great.